Continuing on with societal factors, um, we're going to talk just briefly about health disparities. Since 2003, the Congress has assigned the challenge of assessing the scope of racial and ethnic disparities to the Institute of Medicine. And in addition to identifying the breadth of the disparity, the Institute of Medicine was also charged with evaluating potential sources and suggesting possible solutions to reduce health disparities. Their report is that individuals from ethnic and racial minority groups tend to receive health care that is considered lower quality than individuals from non minority groups. They also indicate that the lower quality of care exists despite controlling for healthcare access factors such as insurance status and income. So when you take those factors out of the mix, whether they have insurance or whether they have access to health care, the care that they receive is still lower quality health care. They haven't been able to identify a particular cause, but one area in which the disparities were found to exist was in the clinical encounter. There was evidence of unequal clinical treatment, which includes stereotyping, treatment uncertainties, and biases. Healthcare decisions based on race and affective distance in interactions with individuals from different ethnic groups have also been reported. So when I say affective distance, what I'm talking about there is their inability to make a connection. There's a kind of a divide in terms of their affect, their mood, their interaction, etc. So, it can be on both sides, because one of the things that is evident about healthcare is people tend to go to practitioners where the provider looks like them. So because there aren't a lot of healthcare providers that look like people or are from diverse populations, people from those populations tend to not seek out care or feel that the person is less competent because they're from a different culture, because they're not able to make that connection. And the healthcare provider often doesn't consider those important factors, such as their values and their beliefs, in the help in the provision of the healthcare services or in the treatment that's recommended. So it can cause this what's called an affective distance. The demonstrating cultural competence, as I'm saying, on part of the healthcare provider, can also determine the client's ability to be able to apply the information that's given, which ultimately impacts their general health. The healthcare provider, the recipient care, and the healthcare system have been identified as key areas of intervention to address disparities, with provider training and education in sociocultural issues highlighted as essential factors in reducing the existing disparities. The Surgeon General also developed a report on culture and race in mental health care, and they acknowledged that individuals from racial and ethnic minority groups are also underserved and not effectively served by mental health practitioners. In addition to practitioner bias, some of the explanations for ineffective care included inaccurate beliefs and the inability of the providers to effectively communicate. Client mistrust and fear were also cited as factors impacting healthcare, which have been associated with the lack of cultural competence in the provision of services. So again, some of this relates to the beliefs of different cultures in what mental health means and what it actually is. In some cases, some cultures view mental health disorders as punishment from God for some transgression that they may have committed, or the family's transgression or something like that. So, there are some beliefs with regard to actually giving credibility to any mental health diagnoses. So it's a little bit more challenging to determine when it comes to mental health, the reasons for the disparities, but that exists on both sides. despite changing societal demographics, the healthcare workforce is predominantly Caucasian, and in some professions, occupational therapy as an example, there's a high prevalence of women. So having these different composition, different demographics in healthcare professions, and because of the high predominance of Caucasian individuals in healthcare professions, sociocultural differences are drastically underrepresented in the provision of services. In addition, the role of the healthcare provider is often viewed as one of authority, which places the recipients of services in a vulnerable and unequal position in the client practitioner relationship, which can be disempowering. So it's incumbent upon the healthcare provider to balance those inequities. Improving cultural knowledge, skills, and attitude can help the practitioner build rapport, minimize misunderstandings and errors, and promote the basic tenets of the healthcare profession that they're in, and the provision of the client-centered, relationship-based care. But in order to truly accomplish that client-centered, relationship-based, holistic care, you have to understand the client's unique perspective regarding the self, regarding health and illness. How do they perceive health and illness, their patterns of care, independence, and other values and beliefs, which are entrenched within their sociocultural identity. Stereotyping, inappropriate decision-making, and discriminatory treatment can occur when a practitioner fails to consider those sociocultural factors. While it's important to understand the factors that comprise professional competence, it's equally important to have sociocultural factors represented within the mission and vision of healthcare organizations. And you see it more and more in the codes of ethics and the core values of different profession and different professional organizations. You're seeing sociocultural and cultural competence becoming increasingly prevalent within those professional documents and within the statements, mission statements, and visions of accrediting agencies. So that's important. Also within healthcare accreditors, for example, JCAHO, the Joint Commission on the Accreditation of Healthcare Organizations, which is responsible for accrediting hospitals, skilled nursing facilities, and other healthcare facilities, supports the standards of cultural competence. And educational standards have also been developed in many healthcare professional educational programs reflecting the need for cultural competence. It's a huge push in occupational therapy, which, as I said, is primarily Caucasian and 91% women. So recognizing the need to increase diversity within the profession is a huge goal in moving forward. And it's the same in many other healthcare facilities. There are some professions that are translating their board exams into other languages so that we can, you're testing the individual's knowledge and not their ability to be able to understand the language. For example, again, using OT as an example, OT has translated the board exam into Spanish and is working on other languages because they want people to be able to take the exam in their native language, even though they have to practice in English if they're practicing in the United States, and that's what the board exam covers. You still want to make sure that you are testing them on their actual knowledge of occupational therapy versus their ability to understand the language. The other issue is that I can use one example from my educational experience. I tried to get accommodations for a student who was not a native English speaker. And accommodations typically are given for people with disabilities when they have a specific diagnosis. Language barrier is not a disability. However, I didn't feel it was fair to test this student in English in the same amount of time as students who were native English speakers. So I tried to get him accommodations to be able to have extended time on testing, because when you're not a native English speaker, you have to translate what you're reading into your own native language, formulate a response in your native language, translate that response back into English, and then either write the response or select a response or whatever format the test is. So, I worked to try to get him accommodations. I was unsuccessful. I did it informally. However, that's one of the things we want to make sure is, are you truly testing the person on their knowledge, or are we testing that person on their ability to understand the language? So, that's one of the challenging. So some professional organizations and accreditors are recognizing this challenge and translating it, but it's, again, not without some controversy, because, the pushback is that, well, they've completed a program in English, are going to have to practice in English, they should be able to take the exam in English. So there are some challenges that exist there. Also, there are some professions that have educational institutions, and through their accrediting bodies, they've been charged with the challenge of providing fieldwork experiences focused on emerging issues such as health promotion, advocacy, and quality of life, with the mission of moving healthcare within the community, and that requires sociocultural competence. And although many healthcare professions support sociocultural competence in theory, there are not a lot of standards of application or uniformity in implementation, and few methods to be able to determine how various principles are being applied in practice. So there are structural guidelines that are beginning to be put into place, but educational institutions are still left to their own devices to manage how these topics are incorporated into the curriculum and how to prepare students for getting out into healthcare practice with people from diverse populations. So there are also many individual considerations that are part of the journey to sociocultural competence. Everyone views his or her surroundings through a personal cultural lens, which colors the interactions that occur. An individual's sense of self is based in part from the sociocultural group in which he or she was socialized, and that sense of self influences the perspective from which the client and practitioner view the world. If individuals don't remove their cultural blinders, the tunnel vision will focus solely on ignorance of values, beliefs, custom, and practices of people from diverse sociocultural groups. It's been reported that in any clinical interaction, there are a minimum of 3 cultures involved: the personal culture of the practitioner, the healthcare provider, the personal culture of the client, and the culture of the healthcare system. And in some cases, a 4th culture can be involved, and that's the traditional medical culture of a person from a non-Western background. So, the culture of the healthcare provider, the culture of the person receiving care, the institutional culture of the healthcare system, and then if a person follows non-traditional medical practices, that brings a 4th culture into the mix. So sociocultural values and beliefs influence a person's ability to participate in their everyday activities, which are predicated on these cultural influences. A person's sociocultural identities are not static, and they change based on the society conceptualization of life roles and situations, such as a parent, grandparent, sibling, immigrant, homeless person, or CEO. 8 years ago, I was not a grandparent. My roles are very different now that I am a grandparent. Think about the people who were rich before the stock market bombed, who are now, having to live paycheck to paycheck, whereas before they lived in $1 million home. So these personal cultural lenses can change, and our sociocultural identities can change based on our life situation. So it's important to understand how sociocultural influences the healthcare, but it's also important to look inward and recognize our own biases, stereotypes, preconceptions to be able to be an effective practitioner or healthcare provider.